Assalamu alaikum doctor. So first, if you notice the picture, we are seeing a boy who is on standing positions. He is on lordotic positions. His abdomen is protruded, and the scapula, if you notice, there may be winging scapula presence. And most important finding, there is calf muscle hypertrophy. If we notice this picture, what we notice that a boy who is standing from the sleeping positions, and how he is standing like climbing. That is Gower sign. We all know that. So the boy is walking. He is on lordotic posture and walking in a waddling gait. Waddling gait, another name is myopathic gait, Trendelenburg gait. And this is an important case, Duchenne muscular dystrophy DMD. DMD come on clinical and also can come on history. So all the management portion covering this. DMD, it is an X-linked recessive conditions and male boy we know affected. So it come with a three scenario in clinical, that is early with only positive Gower sign. So there we can only find Gower sign. 5 to 10 years with all features, and advanced DMD is best reader. Now general observation, what we find: normal speech, normal mentality, 30% with low IQ. Maybe there is crutches or wheelchair in the surrounding. So crutches, wheelchair can be or not can be. Now general examination, what we find: normal shows, maybe there is pes cavus, and if calf hypertrophy, calf muscle is more than thigh, so DMD. So calf hypertrophy is very important features. If ankles wasted, to CMT, Charcot Marie Tooth disease. So Charcot Marie Tooth we already studied, and there is ankle wasted. Remember, calf hypertrophy we find in DMD, and ankle wasted we find in CMT, Charcot Marie Tooth. Now there can be scar on the thigh for muscle biopsy. Scoliosis, severe lumbar lordosis with the winging of the scapula. So already the gait we seeing, there is lordotic posture and winging scapula, and there is waddling gait. There is protruded abdomen, already we notice. Tiptoe walking and cannot walk on the hill. So when he walking, we notice that is a tiptoe walking. Waddling gait, so provocation with the Gower sign. Remember, tiptoe walking is normal up to 3 years. If after 3 years with delayed motor development, so DMD. Now local examination is decrease the TPR, proximal is more than distal, negative Babinski and normal coordinations. If early, then knee reflex lost with normal ankle reflex. If late presentation, there will be ankle reflex also lost. Now complete my examination. I want to complete my examination by number 1, cardiac examinations, that is cardiomyopathy, spirometry, pulmonary functions, neurodevelopmental assessment, that is cognitive, and genetic counseling to the family. Now how investigation I do? First, confirmatory diagnostic, that is genetic testing. We know X-linked recessive disorder. So which chromosome involved? X. And dystrophin gene is responsible. CPK lab we do the CPK, creatine phosphokinase, very high by thousands. Imaging we do the echo and X-ray spine. So echo we do because we know cardiomyopathy, and also in history we ask that is there any racing heartbeat presence, is there any swelling behind the back of the leg, we can ask. Plus pulmonary function test, ECG, geometry for scoliosis. These are the investigation we do. Now multidisciplinary team, I will involve the neurology, cardiology, physiotherapy, occupational, pulmonology, SALT, that is speech and language therapist, genetic, social, psychological support to the child and his family. Treatment, there is no any definitive treatment, but managing the conditions and giving support. First, steroids we give, prednisolone, improve the muscle strength and function and slow down the process of the muscle weakness, muscle weakening. Then etaluren, creatine supplements, treat the swallowing problem, respiratory support, surgery for scoliosis, and treatment cardiomyopathy, that is beta blocker and SCE inhibitor. How about the important questions? The cause of death is respiratory failure, and when it occurs in females, mother, carrier, and father is deceased, very rare. They usually die early. Lyonizations of the X chromosome, Turner syndrome. So remember, it is very rare. Turner syndrome, it can be present. Now another child with same conditions, when the next child, if positive family history, so 50% will be affected, and 50% of the girls are carriers, and if no family history, so 3%, that is. So now about the myopathic gait. Myopathic gait, another name is waddling gait or bilateral Trendelenburg gait. Remember, there are three name. So do the Gower sign. If we find, we do the Gower sign, shaking hands with the child to assist if cannot release your hand. So it is distal myopathy. Comment on the power and reflexes, proximal and distals. Knee joint may be affected with normal ankle reflex. Now advice, wear the bracelet due to the problem with anesthesia. So we give the advice, DMD, wear bracelet due to problem with anesthesia. Investigation we know CPK, EMG, Marai muscle with or without muscle biopsy. Then clue in cases. First we know that myopathic gait where we find DMD, myotonic dystrophy, dermatomyositis, myasthenia gravis, SMA type 3 and endocrine. Here we find. Now DMD there is male child and calf muscle hypertrophy. We already see the video. Myotonic dystrophy when shaking the hand. We notice. Dermatomyositis we know that 5 types of rashes. There is one rashes is around the eye. We know that heliotrope rash and on the knuckle of the fingers. Then myasthenia gravis worsen at the evening. Myasthenia gravis, that is spinal muscular type 3, we find tongue fasciculations. Endocrine, that is hypothyroidism and Cushing. So these are the features. If you did not find due, proceed to the Gower signs and say this is proximal myopathy for DD, which may be syndromic, endocrine, early DMD. Gower sign appear before Wedling gait. So if you did not find the due, any clue, if you not find the clue, then we tell that proceed to the Gower sign and say this is a proximal myopathy. So DD, which may be, it can be syndromic, endocrine, early DMD. Gower sign appear before Wedling gait. So when we cannot confirm, we tell the DD. Thank you everyone. Please do subscribe and share MRC PCH with Dr. Emma Choudhury.